Yes. Before we get started, let me tell you what's coming up. This is really important, okay? Next Tuesday for class, when we have class during class time, there will be posted a video of a basic lecture about formulary management. Next Tuesday, we'll have a video through this class time on formulary management. If you don't come to class, watch it. It'll be on ELC. But it will not be posted until Tuesday because it's my wife's video, and we're both working this weekend. And so it's going to take us all the way to Tuesday to get caught back up. So sometimes Tuesday morning will be available, and you can do it anytime you want to. Now, also on ELC, there will be some assignments for that formulary management class. Okay, because the following Tuesday, we're going to do a mock pharmacy and therapeutics committee meeting. I think you'll enjoy this. On course evaluations in the past, we get several comments about people how much they enjoyed it and like playing along. So all the members of the class, on all locations, are going to be members of the Pharmacy and Therapeutics Committee. We're going to review some new drugs, some policies, and some other items that are real-life items. Groups will be assigned to address different items. We will vote just like a Pharmacy and Therapeutics Committee will vote. I think we'll use clickers for that. And Diane will be the secretary of the committee, which is really the person running the committee. And I'll be in Athens as the chair of the committee, kind of making sure we're on time, banging my fist on the desk, make sure we keep right on time. Because it is a tight fit. We got to start on time in order to finish on time, because it is a tight fit. And I want everybody to have a chance to show off how they do it. So, yes, question? Or is that just a bump with the microphone? Okay. So that's next Tuesday video with instructions on what to do the following Tuesday for the mock PMT. Next Thursday, I will finish up part 2 of this lecture. It's a 2-part. Okay, now this is...
Dr. May?
Yes.
Sorry, I have a question about the second test. Are the 10 points from the investigational drug assignment already added in, or are you going to add those in later?
On the exam, I said you finished it and did it on time. True would give you 10 points. Now, nobody told Dr. Phillips that because she's still grading them. But I wanted to get grades out to you quicker than she would grade the assignments. So if you turned it in on time, you got full credit for it. That make sense? I thought that'd be much better than Mickey Mouse and 1 point here and 1 point there on the assignment. As long as you did it, I just want you to have the experience. That make sense? Is that good?
Yes.
All right. This lecture today, I divided this up into 2 sections. I used to just do the second lecture, but a few years ago I was invited to do a keynote lecture for something called the Ansel Symposium, former dean of the College of Pharmacy, Dean Ansel. They put on a symposium for him each year, just various topics. Well, this year was going to be something to do with antibiotics. And he asked me to do an antimicrobial stewardship talk. So the audience was going to be a variety of pharmacists, practicing, retired. So I thought, well, what would a good overview be that would really teach people about what's the foundations of antimicrobial stewardship? What the heck is it all about? And then after I put it together, I said, wow, if I want pharmacists to know this, why wouldn't I want my students to know this? And it really sets the stage for the details of antimicrobial stewardship to come. Now, I wish you guys would have known, I didn't know, yesterday at the grand rounds, we had an antimicrobial stewardship pharmacist from the VA here in Augusta give a talk. His talk was really good. But it was a little bit too advanced for this class of the 30th person. It was really directed at pharmacists. So it would have been good background information. You could pick and choose what you learned. But I'm going to start off with the foundations, get you guys up to speed so you'll be very comfortable with this topic. Well, if you ever watched the Travel Channel Man vs. Food, it's where a guy is challenged to eat a large volume of food in a specified amount of time. It's a little nauseating watching some guy eat. I think one time he ate 20 dozen oysters or some crazy things like that. A pizza about this big around, the size of a tire on a car. And sometimes he does it, sometimes he doesn't, but it's kind of fun. But I wanted to replace that with Travel Channel's man versus microbes. And guess what? The microbes are winning. Now, here's a bonus. If there's any people who are trivia buffs for 1950s horror movies, can anybody name the movie that picture in the top right corner came from? I'll be very impressed. Oh my gosh, somebody got it. Fantastic. It's from a movie called Them. How'd you know that?
It's my dad's favorite movie.
Is that? It's one of my favorites too. See? Okay, now we get along well. All right, so that's just want to have a giant bug just right here. All right, now, everybody play along. Do not cheat. Everybody close your eyes. Close your eyes. And listen carefully. Over 6 frightening months, a deadly germ, untreatable by the most antibiotics, spread in the nation's leading research hospital. Pretty soon, a patient a week was catching the bug. Scientists at the National Institutes of Health locked down patients, cleaned with bleach, even ripped out plumbing, and still the germ persisted. By the end, 18 people harbored the dangerous germ, and 6 died from bloodstream infections from it. Another 5 made it through the outbreak, only to die from the diseases that brought them to the NIH world-famous campus in the first place. It all stemmed from a single patient carrying a fairly new superbug, Klebsiella pneumoniae, that resists treatment by one of the latest lines of defense, antibiotics called carbapenems. All right, now you can open your eyes. That was my best trailer piece possible. Now, everybody to answer this question. The preceding was an excerpt from Stephen King's new horror medical thriller. B, a voiceover from a movie trailer starring Tom Hanks as a forensic examiner from the CDC. Or C, an August 22nd, 2012 news story from the Associated Press. What do you think? All right, I'm seeing some C's here. That's exactly right. It sounds like a horror movie. I love Stephen King. I read every book of his. It sounds like something that he would invent. Also, Tom Hanks has been in a couple of movies where he's the hero coming from the CDC. I thought that sounded realistic. All of those seem like a good fit. It's actually a true story. So the objectives for today would be to describe factors leading to the need for antimicrobial stewardship, explain why antimicrobial stewardship is a growing necessity, describe the foundations of antimicrobial stewardship, and be able to access some useful resources for approaches to antimicrobial stewardship. All right, so we'll give you some links. And they worked last year. I haven't checked for this year, so hopefully it'll work. Okay, here's some historical perspective for you. In 1928, penicillin was discovered. It was mass marketed in 1944 by Pfizer, which was a huge thing for World War II because you were able to treat patients. 1950, the emergence of microbial resistance to penicillin emerged. So just 5 years after it was mass-produced, we started seeing resistance. Now, I'm going to make a long story short. It was combined from 1950 to 2001. Novel classes of antibiotics were discovered, and as soon as they were on the market, we had new resistant strains. 2001, let me stop there for a second. One of the most fun things, you know how I am about pharmaceutical reps, sometimes I'm a little cynical and mean to them. But, you know, they visited, for 2 times, so I guess that's a little thing to do. Every pharmaceutical rep who's come in my office over the years with a new antibiotic has sat right in front of me and said, to date, there's been no resistance to this new antibiotic. And we don't expect it. And I just laugh. Because 100% of the time, as soon as you start using the drug, resistant organisms emerge, without exception. So it's kind of fun to tease them about that when they make these claims. 2001, the World Health Organization expressed some concerns, and the CDC initiated their Get Smart campaign. Had to do with washing hands and some other things. 2004, Antimicrobial Stewardship Programs as a means to optimize antimicrobial use was published in Pharmacotherapy. And what that was all the articles, it was a summation of all the articles. And if you're on my rotation next year in APPEs, I'll make you read this article, because it gives all the articles that kind of demonstrate that some of the antimicrobial stewardship activities actually worked and helped. In 2007, the Infectious Disease Society of America and the Society of Hospital Epidemiology Associates, I can't remember what this is for, their guidelines were published. This was huge for pharmacy because IDSA is primarily a physician organization. SHEA is primarily a nursing epidemiologist organization. And in this document, they said you have to have a pharmacist on the team. There's an article about the guidelines on how to set up an antimicrobial stewardship team, and it included a pharmacist. Well, guess what? That created a major buzz in the world of pharmacy, like, ooh, I want to get trained so I can get these jobs that are popping up everywhere. So infectious disease specialty residencies were created and boomed, and the job market is still incredibly good. So any of you guys out there who enjoy infectious diseases, that might be an avenue you might think in the back of your head. The job market for that's still really good, and I anticipate it will continue to be really good. Okay, now some factors contributing to the need of antimicrobial stewardship. One, inappropriate antimicrobial prescribing and use. This is a huge one. It's always been true, continues to be true, and we've got to combat it at all angles. One of the reasons for inappropriate prescribing is patient expectations. If a mom takes her child into the doctor to be seen and the child has a runny nose and stuffy and can't sleep and is crying and irritable, that mom or dad wants an antibiotic prescribed. So if you've worked in a community pharmacy, how many of you seen over at Public a bunch of prescriptions for antibiotics for kids? And most of them aren't necessary. So parents have, patients have expectations, parents have expectations. You know, if I go into my doctor, I'll be honest, if I go to my doctor with like a chronic cough and coughing up yucky stuff, you know, there's a 99% chance that it's a cold, right, Meryl? But if I walk out there without an antibiotic, I go, you know, if I get better, even me who should know better, there is that expectation. Antibiotics can be overused, prescribed without any indication. This happens all the time in the hospital. We see a patient, they come in, they look like they might have some chest thing going on, we'll slap them on community-acquired pneumonia antibiotics without really thinking about it. And most of the time it's a viral bronchitis or something like that. Underuse. Patient stops taking the antibiotic as soon as they feel better. Now, the interesting thing about this one is we always thought that was a really bad thing. In theory, that might turn out to be a good thing. Historically, what we thought was you got to treat certain infections 7 to 10 days, some for 14 days, and a patient would take their antibiotic for 2 or 3 days, their fever would go away because the antibiotic's working, and they would stop taking it. Well, what happens in some cases is that you've killed off the majority of the bacteria, but you've left the few that were resistant to the antibiotic. So what happens is they stop taking it, the resistant ones, or mildly resistant ones, start growing, and now you've got a resistant infection. It happens a lot with children's treatment for otitis media. They'll come in, the kid's yanking on his ear, they got a fever, and they'll take antibiotics for a couple of days, the kid's a whole lot better. I mean, antibiotics work amazingly. A whole lot better, so they just stopped taking it because the kid fussed about it every time they took it. They hated the taste of the amoxicillin or whatever it was. They stopped taking it, and then they get a resistant ear infection. So they have to go to a broader spectrum antibiotic. Now, with that in mind, this is still true because even though we want shorter durations of therapy, what you're talking about, instead of 7 to 10 days, now we're going to some 5-day therapy for certain indications. Instead of 14 days, we're going to 10 days for some indications. For osteomyelitis, we're going from 6 weeks down to 4 weeks in some cases. So the underuse might be a good thing if they took it long enough, but it's still potentially bad. The idea that broader is barrier, and we call this the CYA method of prescribing antibiotics. CYA, you want to explain that? You all cover your, in other words, you want to cover everything, so no matter what is growing, you've got it covered so you don't get into trouble as a prescriber. So what happens is you get inappropriate broad spectrum antibiotic, and if this is done in the community over time, that community develops resistant organisms. This it's done over time in a hospital, that hospital will develop more resistant organisms. So you don't, broader is not always better. You have to choose the appropriate empiric choice. And next Thursday, we'll talk a little bit about that, because knowing the proper empiric choice is one of the keys to learning bugs and drugs, contrary to what most people think, you should just memorize bugs and drugs. That is, I'll probably ask the test question. Memorizing bugs and drugs is the best way to learn bugs and drugs. Or looking at a list of bugs and drugs and memorizing it, the best way to learn it. That's wrong. That's not true. The best way to learn bugs and drugs is to think about what disease state do I have? I know what the good empiric choices are for that disease state, and what bugs are most likely to cause that disease state. Now I've got a list of all these empiric drugs, and I know they cover those bugs because it's related to disease. That's a whole lot easier to learn. Okay? So that's the way to learn bugs and drugs. Disease, what bugs cause the disease, and what the proper empiric therapies are. And now you've got a lot knocked out. Failure to change therapy when results return. Let's say we pick the proper empiric therapy. It's broader than what's really needed, but we start them on that. And culture results come back, and it's E. coli sensitive to a very narrow spectrum drug. And you'll say, okay, let's streamline therapy and put them on more narrow therapy. And the physician says, well, I hate to do that. They're getting better. I really don't want to change it. Huge mistake. You want to streamline therapy, or de-escalate, as we call it, from a broad spectrum to a more narrow spectrum drug. That's the right thing to do when you get cultures done. But lots of times it doesn't happen. Failure to get cultures. Well, this is a problem because if you haven't drawn cultures, you're stuck on empiric therapy, which is too broad typically, and you continue to use broad spectrum antibiotics, and resistance will develop over time. Now, this fourth one on the list is really a problem. Cultures obtained before the antimicrobials started. Now, we used to have a problem in our emergency room. The emergency room guys, somebody would come in and they would be really sick, they look septic. Let's get them on piperacillin, tazobactam, and vancomycin right now. And they'll start it. Someone comes from the floor with the order to draw cultures. They draw cultures. But the antibiotic has already started. So guess what's going to grow? Nothing. Because you've got the antibiotic in your system. Even if it's something marginally resistant, it's really hard to grow it because the antibiotic's sitting there knocking down the amount of bacteria there. So then we're stuck with empiric therapy because the cultures are always negative and we don't know what we're treating. But the patient's getting a little better, so we don't want to swap therapy. Huge mistake. Now in the hospital setting, this is a real problem for a tertiary hospital like ours. It's because we get a number of patients transferred from other hospitals, and we're started on antibiotics in the other hospital, so when we get them, any cultures we draw, probably going to be negative. So we've got to treat them clinically and think about when they're getting better and when we can stop the antibiotic. Then the last one, excessive and unregulated agricultural use. Well, you've probably heard this, antibiotics in chickens, antibiotics in feed, antibiotics to help plants grow better. Those are all not good things. Okay? It's good for farmers because it's better yield, but it's bad for society because using the antibiotics to animals and plants creates a system where you're developing resistant organisms and harder to treat organisms. So that's a lot of the factors contributing to the need. Now, let's look at antibiotic prescribing rates by state across the U.S. And this is the latest data available. I'll try to update it, but I couldn't. But you'll find here that if you look at Georgia, we're not too bad. Georgia's not too bad. South Carolina's a little worse. I live across the river in South Carolina, so I need to get on those. And you, Aaron, you need to get on those pharmacists prescribing over there at Publix. A little bit more prescribing over there, but you look at my home state, Kentucky, major overprescribers of antibiotics. Out west, they seem to be doing a better job. Up in the Northeast, they do a little bit better job. But you can see we're probably overprescribing antibiotics throughout the country. And it is a problem in the Southeast. The other contributing factor is the world is a much smaller place than it used to be. Now, what do I mean by that? In the old days, if you lived in Statesboro, Georgia, your chances were you went to Statesboro, Georgia, you might take a trip down to Florida, and that was your life. You know? I'm from Paducah, Kentucky. I I mean, I didn't get on an airplane until I was 22 years old. I never went anywhere except from Kentucky to Daytona Beach, back to Kentucky. We would stop sometimes in Chattanooga to go to Lookout Mountain, Rock City. If you haven't seen Rock City, you should. But nowadays it's totally different. I'll bet you at least 10 to 20 people in this class have done a mission trip. And if you've done a mission trip, you're traveling all over the world, and while you're there, you're bringing things back. There were 900 million tourists crossing international borders just a few years ago. Greater than 10 million refugees, and that number has gone up, crossing borders. Greater than 300 million at religious or other events. 1.2 million medical tourists, that's the medical missions people have gone on. And all these foreign adoptions, there's no way to really track all that, but that's happening a lot. So the world's a smaller place, everybody's connected now. It used to be a problem in one country, now it becomes a problem in multiple countries because of world travel. Here's another potential problem, but I think it's getting a little better. I've updated the slide this year to show you some promise. But look at the total number of antimicrobial agents that were produced from 1983 to 1986. There were 16 new ones. And 1983 was about the time I started doing new drug updates for the state GSHB. And I'd love to talk about antibiotics, because new antibiotics are kind of fun to evaluate the articles. It's kind of one of my things I really enjoy. So I was really busy, had lots of fun doing new antibiotics. From 1988 to 1992, there were only 14. 93 to 97, only 10 new antibiotics. 98 to 2002, only 6. 2003 to 2007, only 4. And 2008 to 2012, there were only 2 new antibiotics. Well, guess what? We're getting more and more resistant organisms. We need more and more antibiotics. So why aren't companies producing antibiotics? So if you're the CEO of a pharmaceutical company, and you have the opportunity to put money and research and development into an antibiotic, which if it makes through phase 1, phase 2, phase 3, it might be prescribed for a small number of patients for maybe 5 to 7 days. And if it's really broad spectrum, when it comes on the market, people like me are saying, oh, this is a great drug, we need to sit it on the shelf in case we really need it. And so we're not going to use much of it. Or if you're that CEO of the medical pharmaceutical company, would you want to produce a new antihypertensive medication that somebody's going to be on their entire life? Much more profitable, right? So there's the incentive with pharmaceutical companies to make antibiotics dwindled a little bit. But that has improved over the last few years because the FDA is giving some incentives to pharmaceutical companies to go ahead and do some antibiotic studies. So they get all kinds of tax breaks and incentives to produce antibiotics. So this is the pipeline, including what's been approved in the last short while of the antimicrobial world. Well, starting here with the mouse on here for you. Deltafloxacin was approved in 2017. So this is 2017 through 2019. 1, 2, 3, 4, 5 new antibiotics. So it's been kind of an uptick in the last couple of years of new antibiotics. Deltafloxacin is a quinolone. It's kind of cool because it covers MRSA. Meropenem vaborbactam was just approved, basically. It's combining a beta-lactamase inhibitor with carbapenem, so it gives a little bit more oomph, and it actually is effective against some KPC-producing organisms, which are the ones that scare us to death in the hospital. Plazomicin is a new aminoglycoside that looks just like an aminoglycoside, except some of the multi-drug resistant organisms that aminoglycosides aren't effective against, this one does hit. So it's a little bit of an advance. Omadacycline, which even though the company is calling a new class of drugs, it's actually a variation of tetracycline. So is ribavacycline. These are both approved, one for community-acquired pneumonia and skin soft tissue infections, the other for complicated intra-abdominal infections. So all these are advances, but what do you notice about all those things? Deltafloxacin's a quinolone, we already have those. Verapinabactam, even though that's the first combination like this, we do have broad-spectrum beta-lactams and beta-lactam-ACE inhibitors already in the market. The first one is carbamazepine. Plazomicin, glycoside. The last two are tetracycline derivatives. See any new drug classes there? No. Okay, so that's a little concerning. But look over the top. Here's some things that may be promising. There's a class of potential antibiotics called formamicamycins. It would be a totally new class of drugs. It was produced by bacteria on the backs of African ants, and it has effectiveness against MRSA. Now, just the way I described it, kind of tells you it's way down the road, because it was just discovered on the backs of African ants about 2 years ago. So whether or not it ever reaches the market, we don't know. At least something's out there with potential. Ramipril is a drug, a combination of two monoclonal antibodies to help treat Clostridium difficile. And that's fantastic. It's what we have now. It's not working all that great. The third drug there has demonstrated, I think it's a new class of drug. It's actually shown in phase 3 trials superiority over carbapenem for gram-negative complicated UTIs. So here's another class that has a little promise. But it's been on my pipeline list for a couple of years, so I don't know why I haven't been tracking it. Solithromycin is a kind of advanced macrolide, like azithromycin, except a little beefier. It covers a bit more resistant organisms, and most notably, resistant community-acquired MRSA. ANS-100 is this is good. ANS-100 is a combination of two monoclonal antibodies to prevent Staph aureus infection. So it's almost like a vaccine to prevent Staph aureus infections on ventilated patients in the hospital, and we're actually studying that with AU. It's kind of exciting to see something being studied. That would be a huge advance if we could prevent Staph aureus infections in ventilated ICU patients. Now, since it didn't look so promising for new classes, I looked at things from phase 2 studies. There were new chemical classes only. So GSK has a peptide deformylase for skin structure infections. However, the speaker yesterday at Grand Rounds said GSK had dropped all antibiotics because they didn't see them as profitable. So this will either be bought out by somebody else or disappear. PMX 30,063. It's a bacteriocell membrane lysis agent for skin structure infections. It's a new class. NVC 422 kills by oxidation for ophthalmic use in Tygo urinary tract infections. And the last one here is a diaryl quinolone, so it's kind of a quinolone, but it's different. That's going to be used to treat tuberculosis, which is an emerging infectious disease again. So there is some hope out there in phase 2, but that's not a lot. So what this means is we have to preserve the antibiotics that we have. The average cost for a new antimicrobial is $70 million to $2 billion to get on the market. So where are you going to invest your money? An antibiotic used for 7 days, or a hypertensive drug used chronically forever, or a new statin, or something that's for long-term use. Most are modifications of existing compounds, which you saw on that list. Early resistance development for each new agent in a new market. I told you that. So no matter what the pharmaceutical rep tells you about the new antibiotic, resistance will develop eventually. So what do? We conserve the antimicrobials we have using good antimicrobial stewardship. Okay? That's why this is such an important topic. Because pharmacists are one of the key players in making this happen. Now, the foundation for any change in pharmacotherapy practice, you've heard me a million times from 4700 say, what does the evidence tell us? Well, what I teach, and some people say I'm a preacher because I preach it sometimes because I'm so enthusiastic, adamant about how important some of this stuff is. In 4700, we talked about statistical approach to regulatory evaluation. We talked about evidence. In this class, we talk about evidence in journal clubs and things like that. We talk about evidence. P&T and formula, we talk about evidence. The common theme here is, what does the evidence tell us? Well, let's see what the evidence is for some of the things that we're doing. Okay, the Infectious Disease Society of America has a grading system for clinical guidelines. Yeah, and there's a lot of different grading systems for evidence, so this is the one that was used for what I'm about to say. Category A is good evidence. Category B is moderate evidence. Category C is poor evidence. The quality of that evidence is 1, typically means there's greater than 1 well-controlled randomized clinical trial. 2 is greater than 1 clinical trial cohort of case control studies. 3 is its opinions of authorities and respected people based on experience. Don't forget that clinical experience is a level of evidence. It's just a fairly low level of evidence. So some of the core strategies for antimicrobial stewardship would be prospective audit with intervention and feedback. In other words, you're monitoring antibiotics that people are on as they're prescribed and making recommendations for changes, dosage adjustments, switching drugs, all that kind of prospective audit of just monitoring. Let evidence for that, having pharmaceutical team monitor antibiotics, A1, cha-ching, right? Awesome. Formulary restriction and pre-authorization. That means we do a lot of this where we say, okay, it's on the formulary, but an infectious disease person has to approve its use. Or we may have something like, we have a lot of this, criteria-based antimicrobials. For a patient to get the antibiotic, you don't have to have infectious disease, but the patient has to meet certain criteria in order for it to be prescribed. And then we look at that on a regular basis. Reductions in use and cost, level A2. That's pretty good evidence, okay? Beneficial as part of a multifaceted response to nosocomial outbreaks of infection, that's a B2. So pretty good evidence to do that. Some of the other things that we do, educational programs to teach people, that's A3 to B2. So good evidence, but not great evidence that education works. Education is a problem at AU because every year we get a whole new batch of physicians. So we got to teach all the time. One educational program is not good enough. We have to do it over and over and over. Guidelines and clinical pathways. We spend a lot of time on that. Pharmacy and Therapeutics Committee, formulary management spends a great deal of time developing guidelines for use. Now you can't take national guidelines for the treatment of community-acquired pneumonia. They're published and they're great to learn in pharmacotherapy, but you can't use just those in a particular hospital because a particular hospital has different cultures and sensitivities, bugs that show up there, sensitivity to their antibiotics based on their usage. Every hospital is different. So you use the national guidelines and then you plug in your formulary agents and pick your empiric therapy based on your sensitivities. So you take national guidelines, but you have to streamline them for your organization. But that's A1, highest level of evidence. That works great. Antimicrobial cycling. Now, in theory, this sounds good. What it means is you have antibiotics on your formulary, and every couple of years you switch them out for different antibiotics so that patients aren't continuously exposed to the same antibiotics over and over and over. And in theory, that makes a lot of sense. But you know what? Evidence has not shown that's beneficial at all. And I don't really know why, but there's no evidence to say that works. It was kind of a hot topic back in the 80s, but it fell out of favor fairly quickly. Antimicrobial order forms. In other words, there's a form to order antibiotics, and by ordering them, you check off what you're using it for, how long you're going to use it, kind of justify its use. Well, that's kind of out of date. I guess it's not. We just do it by computer now. So in our computer system, when a person orders antibiotics, they have to check if it's criteria-based, which criteria it meets. Check that. If you're on rotation B, you'll be checking those to see how often the physician checks this indication. In reality, that patient does not have that indication. That's about 30% of the time. So that requires some education. So going back to that first point. Combination therapies, using various combinations, double coverage for things. There's some evidence for that, not great. Streamlining and de-escalation. That means once you get culture and sensitivities back, you respond to those and narrow the therapy. That's good evidence, A2. Dose optimization. In other words, make sure on the right dose. Now for something like let's say piperacillin tazobactam, we have a dose of that we would give every 8 hours, and you administer it over 30 minutes. Well, there's some evidence out there that if you administer it over 4 hours, every 8 hours, you would be above the MIC much better than if you give it over 30 minutes every 8 hours. So that's dose optimization. You're using your brains and evidence to dose it in a way that works best to cover the bug you're treating. Dose optimization also means adjusting dosage of the renal so you don't get toxicity. IV to PO conversion, that's kind of like the bread and butter of the antimicrobial stewardship rotation. You do tons and tons of IV to PO conversions. The evidence of that being a good thing is A1. Absolutely great evidence. You know why? We've demonstrated this over and over and over on our rotation. Is once we switch somebody from IV to oral, and the team didn't realize, oh wait, they were capable of taking oral, the antibiotics we swap are 100% bioavailable. You're going to get the exact same serum concentrations orally as you get IV. Why not give it orally? You decrease the chance of a line infection. You make the patient more ambulatory because they're not dragging a pole around, an IV pole. And they can take it orally. People say, oh my gosh, they're taking it orally. Let's get them out of the hospital, send them home. Cha-ching. Big bucks, big savings for the hospital, and great savings for antimicrobial stewardship because they get out of the hospital not exposed to other bad things that can happen, like the patient in the next bed having C. difficile infection. I mean, it's a winner, and it's very simple to do. So now, the appropriate use of antimicrobials. Well, I saw this thing, I thought it was pretty cool, adapted from an article in Frontiers in Microbiology. The person had the 10 commandments of appropriate use of antimicrobials. And I thought, wow, these are really cool. So let's go over them. Number 1, use antibiotics only when needed. Teach the patient how to manage the symptoms of non-bacterial infections. In other words, if someone comes in with a common cold, frontline pharmacy, you can recommend the best products for those symptoms and be realistic about when they're going to see improvement. 50 to 80% of patients with viral infections receive an antibiotic. That's horrible. Okay? Number 2, select the appropriate antibiotic. Precise targeting is better than shotgun therapy. Now that sounds obvious, but people, CYAs, I mentioned a minute ago. The broadest spectrum, make sure you cover everything that I possibly have. But if you have guidelines set up, so you have guidelines set up for community-acquired pneumonia, you know what bugs cause that most often in your organization, and you know what antibiotics cover those organisms, so that's what you use. That's not shotgun, that's very precise compared therapy. And then you can go more narrow once you got a culture map. Consider pharmacokinetics and pharmacodynamics. Use the shortest course that has proven efficacy. For example, levofloxacin and azithromycin, the course of therapy for most indications is 5 days. Now, how many times have you seen a Z-Pack and get a refill for a Z-Pack? So they get 10 days of therapy. That's usually not necessary because the patient's not feeling 100% better on day 5, so they get a refill for 5 more days. Well, guess what? Azithromycin stays in lung tissue for a long time. So 5 days of therapy is actually having an antibiotic removed for about 10 days. Has great tissue penetration, hangs around. So we misprescribe that all the time. Levofloxacin and some of the other quinolones, 5 days for community-acquired pneumonia. Evidence is really good. It's just as good as the 10-day course. Encourage patient compliance. Patient counseling, patient counseling, patient counseling. If patients are compliant, they won't develop the resistant infections later. Use combination therapy only when the evidence supports it. This idea, well, I'll use a second drug just in case, is a bad idea. If there's good evidence for using a second drug, that's fine. Number 6, avoid low quality or substandard drugs. Okay, now this one's not a problem because we have, and most pharmacies are doing the right thing. They have criteria for who they're purchasing the drugs from. But there are a lot of counterfeit meds, and so if you're trying to cut corners by ordering an expensive antibiotic through some Canadian market or other kind of market and then dispensing it, there are a lot of counterfeit drugs out there, and you may be giving the patient nothing beneficial. Make sure you're using a reliable source for medications. Number 7, discourage self-prescribing. Oh my gosh, we have, I won't mention a name, but Diane has a name. If you go over her house, she's got drugs for everything. So if anybody needs any help, you go to her house, they get the antibiotic they need, or she's had antibiotics she has to use. Oh my gosh, that's crazy. Of course, it drives Diane even crazier. So if Diane gets in her house and sees anything, she starts throwing everything away. But this is very common. Is, oh, it sounds like you had what I had last week. I still got some antibiotics left over here. What you take? That's a horrendous mistake. Not only because it may not be the right antibiotic, so you get resistant, the patient's not going to get better. What if they're allergic to that medication? I know one case where an anaphylactic reaction occurred. Somebody borrowed some of his antibiotic, somebody else's antibiotic, and it had a name that didn't sound like a penicillin. They were penicillin allergic. That was the situation. Borrowing antibiotics from friends, advice from nutrition stores. Now, sometimes I have to admit that I will walk into GNC and see the person with a white coat on and decide that I'm going to be mischievous, and I'll ask them for some advice. And sometimes you get some really interesting answers about curing all kinds of ills with some of the natural products that are on shelves at GNC. Just to show you, I'm not making this up, my daughter wanted some kind of natural product that actually enhances breast milk production, and it really does work. So I went to GNC and I bought some. I said, the guy behind the counter, white coat on, said, they're wearing a white coat, they don't do advice. So I said, I'm getting this for my daughter to help with milk production, but is it good for anything else? He goes, I said, no, I think I said, what happens if a man takes it? He goes, oh, it's great for men too, it makes you more virile. I said, oh my gosh, this is crazy stuff. So be careful with recommendations from non-professionals, because they will tell you lots of stuff to sell drugs. Number 8, follow only evidence-based guidelines. Not industry-sponsored guidelines, evidence-based guidelines. And sometimes industry-sponsored is evidence-based. It's got to be evidence-based. Number 9, become friends with your microbiology lab. If you work in a hospital or any kind of organized healthcare system where there's a micro lab, become really good friends with the microbiologist. They can give you trends. You can work with them on reports that come out that help you make better decisions. They'll do something called an antibiogram that shows you the sensitivities of organisms or hospitals in the past year, makes you make better selections for empiric therapy. You really need to be friends with your microlab person. I saw ours at a few weeks ago at Mary Poppins Returns, so it was fun to know her well enough to go up and say hi and meet her kids. You should be that level of friends with your microbiology person. Prescribe empirically but intelligently. And I've already kind of mentioned this. Know that local susceptibility trends, and you base your empiric choices off of that. Not what package inserts say it should be good for. Okay, the other half. True antimicrobial stewardship is a marriage. Antimicrobial management, which we talked a lot about, and the other part of the marriage is infection control. Do things to prevent infections. The number one important thing with infection control is 2 words, and that's hand washing. Now, if you think hand washing is lightweight, if you go to the CDC website, they got multiple lessons on how to wash your hands properly. It's really kind of fun. Most of the time it boils down to elbows down, saying happy birthday to you 2 times, and that's how long you should wash your hands. Almost nobody does that. You do hand washing rate studies, and you'll see most healthcare providers fail that. But we're currently being tested over at our hospital for our sterile technique, which always scares me because I never make sterile products except once a year when I'm testing to see if I can do it. So I'm like trying to remember everything, how to get up properly and how to do everything properly. One thing I do for sure is I wash my hands, say happy birthday to you twice, all the elbows down. I know how to do that part. And I just put some general resources here. You can check these. I'm sure some of them works. You know how websites go, they go out of date and not really work. Just some resources on antimicrobial stewardship. Let's see, we don't have time to play it, but if this third one on here is working, you should check it out. It's a YouTube video of this young lady who was doing a project, and she wrote something called the Antibiotic Song. But let me warn you, once you listen to it, it's like an earworm. It gets in your head, and you can't get the song out of your head for a long time, but it is hilariously funny and incredibly accurate for a non-healthcare person. So anyway, you might enjoy that. I'd like to give you some resources. So summary, antimicrobial stewardship is a necessity, it's not a buzz phrase. buzz phrase. You know, in healthcare, a lot of phrases come into vogue, and everybody uses that phrase. Antimicrobial stewardship has been a word since like 2004, and it will be around forever, or at least as long as I can see into the future. It's not a buzz phrase. There are many excellent sources available to support your efforts in starting and refining antimicrobial stewardship programs. We have one at AU, the VA hospital has one. Most organized healthcare systems have a pharmacist who's working with IV folks to do this process. Using students, I'm not opposed to using students for things, because if students are being used to do stuff, they're learning because they're doing it, and that's the best way to learn. I'm going to show you, oh yeah, I don't have that slide until the next Thursday. I'll show you how students have benefited our organization just on a 5-week antimicrobial stewardship. This is my 2 oldest grandkids, but I thought this was really captured the spreading infectious disease thoughts in the brain. My grandson Howie, who's now 8, is scared to death of his sister's kisses, but he'll get cooties. So that's pretty fun. All right, any questions about this material today? Next Thursday, we'll go into more depth and practicality of how to actually do some of this stuff I talked about. So that'll be part 2, and hopefully you'll enjoy that. Between now and then, though, and actually the last lecture of the year, stick in the back of your brain, because I know a number of you at the class will be going into community pharmacy. Start now thinking about ways that you could implement some antimicrobial stewardship concepts in the community, because currently that's not taking place. And community-resistant organisms are on the rise. So we're starting doing a fair job. I'm not going to say we're doing a great job in hospitals yet. We're doing a fair job. I wanted to get to excellent. But the community, we're not really doing very much. And I've got some ideas, and I want you guys to be thinking about it. And we'll talk about that in the last class of the year. We talk about, I think the lecture called DI-Centered Clinical Services or something. All right, I'll see you guys next Tuesday. Remember, watch the video. You'll get instructions for assignments. Make sure you do your assignments. That will be part of your test grade on the final exam. So make sure you do your assignment. And next Thursday, we'll finish this up. Okay? All right, I'll see you guys next week.